Welcome to this educational presentation from Professor Mohammadi's Teaching Archives. Today we are focusing on EEG artifacts that are particularly important in neonates, infants, toddlers, and children. The key idea is that pediatric EEG interpretation is never just waveform recognition. Age, behavioral state, feeding, movement, caregiver handling, and the bedside environment all shape what we see on the tracing. Some of these patterns can look rhythmic, focal, or sharply contoured, and that is exactly why they can be mistaken for seizures. Throughout the presentation, we will use a practical framework: field, evolution, time locking, video, and polygraphic channels. Next slide, please. Pediatric EEG is artifact prone because the child and the recording environment are both highly active. A neonate may shift rapidly between behavioral states, breathe quickly, be fed, be soothed, or be surrounded by ventilators and monitoring equipment. A toddler may cry, chew, move, or pull on leads despite the best effort of the technologist. These factors do not simply make the tracing messy. They can create patterns that look suspicious. A rhythmic artifact may look ictal. A focal artifact may imitate a neonatal seizure, and sharp muscle or electrode activity may be mistaken for epileptiform discharges. The safest approach is to interpret the EEG signal and the clinical situation together. Next slide, please. The first group of neonatal and infant artifacts is important because these patterns are often rhythmic. Respiration and ventilator-related artifact may produce delta-like waves, especially when chest motion or tubing movement is transmitted to the electrodes. The key clue is time locking to the respiration channel. Pacifier or sucking artifact can create repetitive bursts with jaw EMG, and if we look only at the EEG channels, it may resemble an electrographic seizure. Patting and rocking are also classic pediatric mimics. They often start and stop with caregiver handling and lack true electrographic propagation. The critical question is whether the pattern evolves like a seizure or simply repeats mechanically. Next slide, please. Here we see an example involving an 18-day-old boy with diaphragmatic hernia, pulmonary hypoplasia, and severe scalp edema related to hypoalbuminemia, who had been on ECMO since birth. The EEG background is very low voltage, largely because of scalp edema. The important teaching point is the artifactual low voltage rhythmic 7 Hz theta activity seen in the right occipital electrode. This pattern was caused by a high-frequency jet ventilator, which can vibrate the patient's body and the recording electrodes. Because it is rhythmic and focal looking, this artifact can mimic a focal electrographic seizure. Next slide, please. This example shows sucking artifact in a 5-day-old neonate with hypoxic ischemic encephalopathy. The key finding is spike-like activity in the bitemporal regions. In a neonate, this can easily attract concern because true neonatal seizures are often focal and may be subtle. However, when spike-like or rhythmic activity appears during sucking, the reviewer should look for jaw EMG, oral movement, and time locking to the behavior before concluding that the pattern is cerebral. Next slide, please. This example demonstrates padding artifact, one of the classic pediatric seizure mimics. Padding can sometimes simulate an electrographic seizure because it produces rhythmic activity on the tracing. The distinction is made by looking carefully at the pattern. Artifact tends to be invariant, mechanically repetitive, and without true frequency evolution. A true seizure, in contrast, usually evolves in frequency, amplitude, morphology, or spatial distribution. Next slide, please. This example reminds us that not every unusual waveform comes from the patient or the brain. The artifact occurred because of movement of a balloon near the EEG head box. This is a useful teaching point. Environmental sources can produce striking waveforms, and the source may only become obvious when the EEG is interpreted together with video, observation, equipment position, and technologist annotation. Next slide, please. Equipment and state-related artifacts are particularly important in the NICU. Ventilators, radiant warmers, monitors, pumps, and bedside equipment can add electrical or mechanical contamination. Condensation in ventilator tubing can even create mixed slow and fast bursts that look alarming if the source is not recognized. Neonatal sleep introduces another clue. Slow roving eye movements can produce large frontal deflections. These are not seizure markers. They are part of interpreting the behavioral state. In the NICU, the safest reading is based on 3 elements together: the EEG pattern, the clinical context, and the auxiliary channels. Next slide, please. In toddlers and young children, oral and jaw-related artifacts are very common. Tongue movement produces glossokinetic artifact because the tongue behaves like an electrical dipole. Crying, vocalizing, and tongue motion can create broad, slow potentials. Chewing and bruxism may generate sharp temporal or frontal activity, and because it can be rhythmic, it may look epileptiform. Feeding, sucking, crying, and other oral motor behaviors also add EMG contamination. The practical clue is to look for EMG bursts, inspect the video for oral movements, and see whether the suspicious activity disappears abruptly when the behavior stops. Next slide, please. Some pediatric EEG patterns are created by care itself. Repositioning, burping, feeding, comforting, parent handling, bedside nursing, and lead pulling can all generate EEG changes. These may appear as abrupt, diffuse disturbances, attenuation, rhythmic slow activity, or sharply contoured movement artifact. The pattern may start and stop exactly with the care event, and its frequency may vary with the intensity of movement. The recommended response is practical. Pause, annotate, review the video, check electrodes and leads, and repeat or reposition if the answer remains uncertain. Next slide, please. Artifacts mimic seizures because they can reproduce the visual features that worry EEG readers. They may be rhythmic because breathing, sucking, patting, or machines operate in cycles. They may appear focal because the source is near one electrode, one scalp vessel, one tube, or one lead. They may have high amplitude or sharp contours because movement, electrode pop, and jaw EMG can be abrupt. And in the pediatric bedside environment, the source may be outside the brain, but very much present in the clinical scene. Rhythm alone is not enough to diagnose a seizure. Next slide, please. A structured checklist protects us from overcalling artifact as seizure. First, ask about the field. Is the activity distributed in a physiologically plausible way, or is it confined to one electrode or one derivation? Second, look for evolution in frequency, amplitude, or spatial distribution. Third, check time locking to respiration, ECG, sucking, patting, or equipment. Fourth, correlate the EEG with video, annotations, and polygraphic channels. Finally, reassess after sleep, electrode adjustment, reduced movement, or removal of the suspected interference. Next slide, please. The workflow begins before the EEG starts. A child-friendly setup, good impedance balance, thoughtful scheduling around feeding and sleep, and appropriate auxiliary channels can prevent many problems. During recording, continuous observation and dense annotation are essential. Feeding, patting, crying, repositioning, nursing care, and machine cycles should be documented. During interpretation, start with age and behavioral state, compare suspicious patterns with video and polygraphic channels, and return to the field, evolution, and time-locking questions. Careful clinical observation is the most powerful artifact reduction tool. The take-home message is straightforward. Artifact recognition is not a side skill in pediatric EEG. It is central to interpretation. A pediatric artifact is often fixed, mechanically linked, or tied to handling, while a true seizure usually evolves in morphology, frequency, amplitude, or spatial spread. When the distinction is uncertain, avoid making a decision from the waveform alone. Return to video, annotations, ECG, respiration, or EMG channels, and electrode quality. Context protects interpretation and helps prevent both false seizure calls and missed cerebral activity. Next slide, please. This presentation was selected from Professor Mohammadi's educational archive. Thanks for watching.